All right, standard ASA monitoring. That's something that you're gonna see um, when you're a student rotating through anesthesia. When you're a resident, you're gonna see that coming up on boards. And when you're getting sued, the lawyer's gonna say, "Did you use standard ASA monitors?" So ASA stands for the American Society of Anesthesiologists. All right. So what does that entail? Um, Anytime you give anesthesia, except in emergencies, you should use a standard ASA monitoring. That's what they want. Maybe exceed it, meaning if you want more monitoring, such as an arterial line, a central line, a pulmonary artery cath, brain oximetry, pulse, stump pressure. There's many more monitors that you can use, EEG, evoke potential. So there's a lot of monitoring that you can do that are not standard. These are what they want you to do. Is they're saying that these are the basic monitors that you should be considering, which I agree with almost 100%. They write in their statement, these do not guarantee any specific outcome. And then with the evolution of monitors, so that means it just gives them room to, if they want to add more as time goes by, they can do that. And then what they're describing is general, regional, and MAC, monitored anesthesia care. This obviously doesn't apply to OB. All the OB guys are like, stay out of the way we do things. And then just remember that the guys that do this are academics, so they don't have the answers to everything. Ask your professor who's written 80 million papers. Ask him when was the last time he actually did his own case, and it's probably gonna be quite a while since he's actually done any actual work. So take that with a grain of salt. Always use your own best judgment. So standard 1, it says a qualified anesthesia personnel must be in the room at all times with general, regional, and monitored anesthesia care. So that makes sense. The guy that did Michael Jackson's anesthesia, was he qualified? I don't know. Maybe not. With the time has passed, anesthesia residency has gone from being a 3-year residency to now a 4-year residency. And then now they're adding on a bunch of fellowships. Before you can just come out and start doing cardiac cases. Now they say, no, you need to have 1 more year to do cardiac fellowship. They're trying to throw in other fellowships as well, such as regional anesthesia. Pretty soon they're going to be like, oh, you can't do a nerve block unless you had another year of fellowship. And then they also said, but a CRNA can do it too. So they're like, oh, okay, we're going to go from 3-year residency to 4, but it's an easy job, so a nurse can do it. So I don't know. They play their games, and you just have to either play along or play your games as well. And so regional anesthesia, that's one of the ones where it's going to be difficult to find a center that is going to just continually monitor a person that, for example, if you're doing a nerve block on the arm and then you want to do it in the pre-op area, it's going to be hard to find a hospital where they're going to say, oh, that an anesthesiologist needs to stay with that patient, even if they didn't give them any sedation. So that might be one of the problems you might run into in the real world. MAC anesthesia, obviously it's in the word, monitored anesthesia care. So should always be there. I think the main thing is going to be when you want someone qualified, if you believe or you anticipate that the anesthetic that you're providing are going to have change, where there's going to be changes in the patient's status, such as respiratory status, such as blood pressure. If any of those things with the anesthetic that you gave, if any of those things can potentially change like rapidly, and if you're there and you can do something about it, then that probably should be met. That's when you should probably be there. Emergency situations that you may be able to not do this at all. It depends on the emergency. So that's that. The second standard, it says, this is just paraphrase. It's not like I didn't copy it, but during all anesthetic, patients' oxygen, ventilation, circulation, and temperature shall be continually monitored. That's pretty much straightforward, makes sense. But how do they want you to do that? So with the oxygenation, they want you to adequately assess the amount of O2 going in to the body, and then the amount of O2 that's in the body, or specifically in the blood. You can measure that by there's an oxygen analyzer, and for those of you that are in residency, there's always questions on what an O2 analyzer is and how it works, and the Clark's something, I don't know. But you'll have to know that. Just learn it right before the test, and then you can forget about it, because you probably will forget about it later. But that's a method of analyzing the blood, the inspired oxygen. And then there has to be a method of analyzing blood oxygenation, a quantitative method of assessing oxygenation. All these things you're able to apparently waive. You don't have to do it, but they mention it has to be an extenuating circumstance. So if you ever get into litigation, then that's something that you can, it kind of like leaves it open to where you can defend yourself if for whatever reason you weren't able to use any of these monitors. It also leaves room for corruption, if you ask me. So for example, if I've seen a lot of doctors, right? They're not in it for the money. That's what they say. But I've seen people where they put invasive monitors they shouldn't have been putting. The scumbags, basically, where they put a central line on a patient that didn't need one, on an arterial line on a patient that didn't need one, nerve blocks, especially in hospitals where they charge by the procedure and they're not charging you hourly. So you can, there's a lot of ways these guys can get away with it. They can just say, well, the patient had this, and it's kind of hard to argue that, man, you shouldn't have done that, but they do it anyway. There's people are people, like the song goes. Ventilation. They want you to basically monitor the CO2 and minute ventilation rate. And there's a difference between continually and continuously. So continuously would be like an arterial line, monitoring on second to second, and then continuously, all these things need to be done like, minimum of 5 minutes is usually what they want. And 5 minutes is usually how billing goes too. Like they charge every 5 minutes. So that, but if they have an endotracheal tube, they do want you to use an end-tidal CO2. If there's no LMA or AT tube, there has to be a way to monitor it. So that doesn't really say that they have to have a capnography. And that goes into situations like if you get a job working in Beverly Hills, or these guys that are doing surgeries for cash. These guys, you'll see some of them are really, they're really, sketchy, and some of them are just flat out scumbags. They'll do anything to save money. So they'll be operating on a patient and there's no CO2 monitor, and so some of these guys, they'll just get away with it. But I've seen that. It's bad, but it does happen. A machine, if you're using a machine, must have O2, a way of measuring how much O2 is going in, and then it must have an alarm if the circuit disconnected. And these things, sometimes they'll I see a lot of anesthesiology walk in and you can't even hear the alarms because they turned it down. They don't want to hear the beeps and stuff like that. And that's poor practice. Don't do that. Just monitor your beeps, and then your machine should be able to alarm you when the circuit disconnects, which happens quite often, for whatever reason. When you're moving a patient or something like that, it will happen to you. And then also, you don't want to give mixture, you want your ventilator to be giving oxygen and not some other gas that you don't intend to give. So there has to be an analyzer, and there has to be an alarm to go off to tell you that, hey, there's no more oxygen in this room. So you're also supposed to check your reserve tanks in the morning. So that's just that's not part of this, but it is part of how you start your day and making sure that everything is working okay. All right, and circulation. They want you to have an electrocardiogram. So 3 leads is most surgery centers where they're low profile surgeries, or if you don't expect any arrhythmias, they're usually 3 leads. If you're doing more complicated cases, you'll want to use 5 leads. And I won't go into why, but just know that 3 is standard, 5 is extra. You have to have a way of measuring blood pressure, and then they want a minimum of 5 minutes. Obviously, if you have arterial line, you'll have it less than 5 minutes. They want you to measure heart rate, which makes sense. They want you to be able to palpate for a pulse. You can do, you're next to the head most of the time. You'll be able to feel the carotid. They want you to have some method of auscultation of the heart. Now, sometimes if you put in a temperature probe into the esophagus, sometimes they'll have little connections where you can connect a stethoscope and you can hear the breathing and you can hear the heart rate. That's really good. A lot of people in the olden days, they used to use that a lot more. Now it's people are getting lazier and lazier and they don't do that. But it's really good. If you were to use that on all your patients, I think the complications would be a lot less, because you could catch things right away. And then they want you to some way of measuring a tracing of the intra-arterial pressure. So usually your pulse ox will show you the pressure differences, and that's the main reason for that is that if, for example, the bovine is electrical current, and that may interfere with your EKG. So if your EKG shows that it looks like their patient's in VFib, but you look at the pulse oximetry and then you have a normal waveform, then it's just artifact. But if you see a crazy electrocardiogram EKG leads, and the pulse oximeter tracing is not showing a good waveform, then you're probably running into a situation where there's an arrhythmia or something like that. So that might be dangerous. So that's why you want to have those two things. And then the last one, temperature. But they don't specify if it's skin temperature, mid-esophageal, bladder temperature. You can, doesn't really tell you what, but they want you to monitor it if you expect a clinically significant change, if they're anticipated or intended, or suspected. And the main reason for that is that you want to see if the temperature drops too low. So whenever you induce general anesthesia, after a while, that temperature can go real low, and if it goes low, it can affect the hemodynamics of the patient, and you won't be able to fix those until you fix the temperature. So that's why they want you to measure the temperature. If you're just doing light sedation or Versed, fentanyl, something like that, I guess you can get a temperature baseline, but you don't have to continually monitor it. You should, just for documentation purposes, but is it something that I don't really expect there to be temperature changes in someone where I just gave hardly any sedation to. Also, they want you to, what if it's like regional, and that's all you did? So, in the OP area is when you give a spinal, the patient's awake, and what are you gonna do? Put a esophageal probe in an awake patient? No, you're gonna put a skin temperature, I guess you can, but no. So those are the standard ASA monitors. You will see those on multiple tests, and you'll see them on boards and on and usually that's how they'll word their question. You'll say, like, apart from standard ASA monitors, I will do this, and that. Or they might just straight up ask you, what is the standard ASA monitors? If you read this, or if you listen to this, now you know.